The parts of the body, but no polyps, allergic rhinitis. We know that the effect is short-lived. So I've never understood how putting DEXA into the endolymphatic sac or into the ground or whatever it is gives you relief for such a long period of time. Is there an explanation? The other thing I wanted to know is you're putting gentamicin into the ear, into the round area. How does it reach the vestibular labyrinth? Malvik, I'm sure you've read up about it.
No, it basically picks up the black cells and
Thank you very much for that term. So, it is not only destruction of the vestibular hair cells that you're talking about, but there is some proof to show that gentamicin even attacks the dark cells, which are responsible for endolymphatic production. And therefore, the old concept that you keep on giving gentamicin till you get no caloric response, instead of that, at least my experience has been, I give one injection, wait and see, and sometimes they get relief for some time. After some time, they come, you give one more. You don't have to go to the end point. If you just weaken the labyrinth and you are attacking the dark cells, the production of endolymph is thought to be reduced. Nobody really knows what happens, but at least in my experience, although initially we were doing what you're doing, we have slowed down on that. We come in, give one injection and then just wait for some time and see the outcome. And I'm surprised to find that just weakening of the labyrinth seems to help.
So that is what literature is saying these days, that reduce the nose and as the frequency.
Yeah. Talked about the sham surgery. I tell you one very interesting case. Dr. Karnik was demonstrating endolymphatic sac decompression at a workshop. We used to have this temporal bone. We started way back in 1976. And he opened up, and something went wrong with the patient's blood pressure shot up. He had just opened the mastoid, and the bone was just oozing blood. And 210 was the blood pressure. So we said, sir, I think that's, so he said, I'm sorry, we'll close the surgery. The bleeding was not stopping. I don't think he had surgery set at that time. So he just packed the whole mastoid with a big gauze and took it out sutured the wound and took it out from here. Patient was discharged after a few days, and I remember that patient coming back year after year and falling at Dr. Karnik's feet saying that you have completely cured me of my body. Okay, and regarding sac decompression, and suddenly you're trying to decompress the system through the sac. And here comes Monish and says he's written an article, we close the duct. So you stop total communication, and still it works. And there's an article by Will Gibson from Australia, cochlear implant surgeon. His surgery for the endolymphatic sac is excision. He excises the entire sac and still gets the same result. So I really don't know how that is supposed to work. Okay. Vascular loops. Is Shishir Goswami in the audience? Shishir, are you there? You were there in the morning. He did his thesis. So what we did was, when he was postgraduate with me, I said, go down to the postmortem room and every time the skull is open, take pictures. When they open the skull, they decap it and then they take out the brain. I said, before they take it out, just take pictures. And the number of times he found loops of vessels going into the internal auditory meanders, touching the nerves, was ridiculously high. But not everybody suffered from symptoms. Facial heavy spasms is perhaps much more recognized as a vascular loop syndrome than even vertigo. Klaus Hyde came, we did a case. Fantastic results, slight facial weakness after handling, that passed away. 1 year later, the hemifacial spasms came back. So, in all these patients, when you see a vascular loop, to be absolutely sure that your tinnitus and vertigo is because of, the episodic vertigo is because of vascular loop, again is rather presumptuous. Also, there is proof that Meniere's disease, if just treated conservatively and you pull on, after about 7 to 8 years, it seems to burn itself out. So rather than be aggressive, if you can keep the patient going. I have a astute practice of vertigo. I become a dumping ground. So it's a very easy way of getting rid of the patients and send them to me, and you keep on treating them conservatively over a period of time, many years, burns itself out. That's what the natural history of many years is, about 7 to 8 years. So you could wait rather than be aggressive on the treatment. Vestibular nerve curing the disease on the other side. That is something which is new to me, but so I won't say anything on that. Treatment of superior semicircular canal fistula. I published that because I did it under local anesthesia, and I was lucky that I could lift up the dura, I could see the semicircular canal, and when we put saline, your shy incus sign, what Dr. Anand described, you can't see the incus, put saline and the incus is seen by diffraction. So I would put saline and you could see the fistula, and then I would take a ball probe, dips and the patient on the table because I'm the local hero. But then I realized, why did I not use an endoscope 30 degree, and I would have been able to. So at that time nobody was talking about endoscopic ear surgery, but it would have been so much simpler for me to just use an endoscope, push the dura up with that, and I would have been able to see the fistula. But if you are talking about plugging the semicircular canal, you don't have to go to the fistula. It's so easy for you to identify the superior semicircular canal in the mastoid. You have a lateral canal, and then you drill a little more deep and you see the superior canal. So let the fistula be where it is. Blue line, I remember Professor Pester, when we were training with him, he would make us do temporal bone dissections, a double blue line, and then take off a piece of the bone without disturbing the end ostium inside. So if you do that technique, you blue line the semicircular canal, just take off a bit, and then you can plug the semicircular canal right from the mastoid. There is no need to go and plug the fistula, because the moment you plug the semicircular canal, the job is done. And lastly, singular nerve neurectomy for DTP. I was attending a conference. This operation was described by Richard Gasick, Big Gasick. And it was Herbert Silverstein, a very big name in otology, who was presenting. And he had to set 16 cases of singular nerve neurectomy. And Mirkotos, the same Mirkotos from 1981 article which you showed over the sham surgery, was sitting there like an old fox. And he says, have you ever had, first he said, sometimes people have bilateral semicircular canal. So did you do bilateral surgery? He said, yes, no problem. I could do a bilateral singular nerve neurectomy. So, okay. Have you, in any of your cases, got sensory neural deafness after surgery? And the answer was, yes, in 2 or 3. If you've done 16 operations, then you would know whether it was 2 or 3. And then Mirkotos said, let me get this straight. You've got a condition which you call benign paroxysmal positional vertigo. In 16 cases, you've got 3 cases who develop sensory neural loss, and you are willing to do it bilaterally. Dead silence in the auditorium. So I don't think that operation is done anymore. So surgery for vertigo for desperate cases, yes, but I think one has to be extremely conservative in jumping the gun, because once you destroy, there is no coming back. And then you find out that the patient had a little bit of a central nervous system problem. You have meaning worse. Compliments to all the panelists, because I think you were bang on